Welcome back to the Wellness Grow Show. Today's guest is Vlado Bosanac, founder and head of strategy of AHI, a digital health company using smartphone based assessments to help identify chronic disease and metabolic risk earlier at scale. AHI turns a mobile device into a risk assessment tool using a combination of camera based signals and guided tests to generate biometrics and risk indicators. The big idea is simple. If we can spot risk earlier and route people into the right care pathways sooner, we can reduce the human and financial costs of chronic disease. So, in this conversation, we'll unpack how population level screening is changing, why scalability matters, and how AHI thinks about partnerships across insurers, pharmacies, and governments, and what it takes to turn assessment into real prevention action. Lotto, welcome to the show.
Thanks, Scott. Pleasure to be here. Thank you for having me.
Yes, excellent. So let's talk about you've been building this space for a long time. What was the original problem you set out to solve, and why does it feel even more urgent now?
So originally we started this in 2014, and if you like, the goal at that time was to really enter the weight loss and gym industry, where we created a body scanning capability that allowed an individual to dimensionalize their physique and see if the changes are happening in the places they were hoping them to. And it gave them a way to accurately see the change utilizing the mobile phone. So we built a body scanning capability, and over the few years after that, we built a DEXA scan mimicking capability to show body composition as well. What we found with the escalation in the insurance market and care is we started being approached because of this capability by insurers and more in the med tech space to have a look at how they can identify the risks in a human based on certain circumferences on their body. So we escalated into more of I'm going to call it a health tech, not a med tech. We've been careful not to be a med tech because that comes with a lot of hooks and barbs needing different approvals and bits and pieces, which would slow our go-to-market down. So yeah, we started as a body scanning capability to allow people to accurately measure themselves with their training and their fitness routines.
Okay. And then so if they're using this for the first time, what does a person do on their phone? And then what do they get back at the end?
So we have two primary products now. We have our digital health check, which is a PPG of the face using the mobile phone. So basically we're looking at blood flow, pigmentation changes. From that, we're able to pick up 28 different measurements, core vital signs that a medical practitioner or a care provider would want to find: blood pressure, stress, heart rate, respiratory rate, and so on, with a number of other biometrics that we can bring together to give them an initial assessment. That then, if we find, and we do this in a red, amber, green, so a traffic light system. So if we find there are lots of ambers and reds, we try to escalate the individual into what we call our digital health assessment, which is a 4-stage protocol, which includes the Harvard step test, up and down on a step for 3 minutes. We take a pre and post exertion heart rate by having the person sit down to see how fast their heart rate recovers from their pre-exertion heart rate. We do a body scan and we do the face scan also. So we have a computational capability, which is probably the secret sauce. The capturing, lots of companies do a face scan, lots of companies do a body scan, lots of companies do a PPG, but what they haven't done is built the downstream computational biology to say, well, what does all that mean when you bring it together? When we do the 4-stage assessment, we get 84 biomarkers and measurements. So we really have an in-depth knowledge of that human, and we're able to then share that with care providers, medical practitioners, insurers, depending on who it is that we're dealing with at the time, because we're a B2B, we're not a B2C. So the way our technology works is we provide it to large, already existing user bases, and then that organization offers the technology within their organization to be utilized, whether that's an insurer, a government population health screening capability, a diabetes prevention or care provider, and so on.
Okay. So you've been clear that this is not a diagnosis. So how do you define the risk assessment? How do you ensure that the input is or the output is actionable without overstepping?
Good question. What we do is we identify risk, but we don't diagnose, such as what a doctor would do. Okay, so what we do is we provide clinically relevant information. If you sort of thought mimicking what I'm trying to do when I walk into a doctor's surgery, he's going to listen to my chest, see what my respiratory system's like. He's going to check my heart rate. He's going to do a blood pressure test on me. He's going to weigh me. And all of those things lead him down a certain pathway to whether he is finding indicators of chronic disease. What we've done is we haven't created the science, we've digitized it. We've created an ability to capture this digitally in a way that's been independently validated. So when it's given to an insurer, a medical practitioner, a healthcare provider, they can trust that information. So they can look at that information and say, I will now diagnose as the medical professional what that information is telling me. Where this really hits the sweet spot is there's too many people filling waiting rooms that are not ill, that they have got episodic care that they're trying to deal with. Chronic disease is something that can be prevented if detected early. So the beauty of the application is it shows escalation in change. So we might measure you today and you're borderline. Most medical practitioners, insurers, care providers would say, right, I want another one off you each month for the next few months to see if escalation is taking place, because chronic cure doesn't just drop all of a sudden. It's a slow burn and it finally hits you at a point where medication, hospitalization, and it's too late. You could have caught it much earlier because it's a lifestyle disease. And when you look at the global spend in this particular market around chronic disease and diseases that can be averted, you're talking about 80 to 86% of most healthcare spend in developed countries. So it is highly expensive. It can be controlled, and early intervention is what everyone is talking about, but there hasn't been a tool yet delivered to the market that can do that until AHI developed this sequencing capability.
Okay. So you mentioned chronic disease is where so much the global healthcare spend is concentrated. And then in your view, and I think you touched a bit on this, like, so tell me maybe if there's more to share on this, where are most systems failing today? Is it the late detection, the access, that adherence, or something else?
It's definitely the late detection, because as humans, we tend to not go to the doctor until we feel like we're going to die, right? We really, and I'm European, so my dad just taught me to tough it out. The truth is, if I was being checked more regularly, and the gold standard at the moment, just jumping around a little bit, is if you only got checked once a year by your doctor. Very few people do it. The fact is 90 days is enough time for you to dramatically change in your position of your health, especially if you're on the borderline, on the cusp of a metabolic condition. And most of this is correlated directly back to our lifestyle, eating habits, and central adiposity. How's the stomach looking? Is it, large? Is it fuller than it should be? And this is where BMI fails us, because a lot of doctors will measure you and weigh you and get your height, your weight, your gender. And they create this BMI score, which we know is horribly inaccurate. So you want to be able to get this accurately, because there's a big difference between me, 120 kilos, and The Rock, right? If I was 120 kilos versus The Rock, who is, Dwayne Johnson's stacked, he's well built. My 120 kilos, the composition is going to be completely different. And that's where the failure of BMI works. Just because I'm the same height and weight doesn't mean I'm the same composition. And that's why we created the tool to be able to accurately diagnose these markers. And there are decades of medical science and prove that these are the markers that you should look at: waistline, neck circumference, central adiposity. There are things that are just obvious indicators. Now, if you can get into the doctor, he will see these things, but not everybody does. If they had a way to transition this information to a medical professional earlier to show that that is stepping out and getting worse, he could bring you in earlier and get you onto simple things like metformin. It's a $5 drug in most countries, not in the US. And it's something that can, stop you getting type 2 diabetes if used correctly, because it maintains your blood sugar levels so well. So there are things that can be done very early that bring you into a care pathway that is the right one for you as an individual, if they could get this information. So if we roll back to what we were talking about, early intervention is the key, and that's where the failure is right now.
So thinking about like, why does the phone matter? A lot of companies say they do a scan, and you had made a point earlier that the magic is not just the scan, it's what happens behind it. So what's the real advantage of leveraging computation on the device?
It comes in a different number of layers. One, the ubiquity of the phone. There are 6 billion of these smartphones in the world, so access to more humans is a natural fit with the mobile phone. Secondly, after COVID, the trust in our mobile phone escalated exponentially. Mobile phone is used more for health issues now than banking. I think 67% versus about 54%. And you would never have thought that, but I've read the statistics. People use their mobile phone far more now for their health needs than they do for banking. Okay. So, and that's a hell of a statistic that we love. It's to our advantage. But I think when people can control their own environment with their own mobile phone, they're disseminating their personal information to one individual provider. I think it makes it a lot easier for them to trust the ubiquity of the phone and give that information to give them better care. I don't think there's anyone that gets up in the morning doesn't care how they're feeling, but can they action it? Are they aware of it? That's where we fit in. We can help them action it and move with it, know what to do.
Yeah, and it's kind of like even sensing if you do feel something off and you've got some data to like kind of back it up. You're like, oh, maybe I should take a little easier today, or I'm well rested. Maybe it's a good day to get in some exercise or
Yeah.
something like that. Okay. So you had talked about governments wanting to screen entire populations. What changes when you design for millions of assessments, not thousands?
A number of things, really. If you can do this at population scale, and everybody straight away thinks about latency and delay, and we remember years ago with apps on the App Store, they'd crash if too many people ran at them at one time because they were so excited to use them. That day has changed. The capability of these phones now is exponentially different. And the other thing that we do is quite different to other organizations is we do the computation on the phone. So that way we're not relying on the cloud to be ready and spun up to take that information. So if millions of people wanted to use our technology at one time, well, it's operating on their mobile phone. It's not until they push the data to the provider of the technology that it starts to use the cloud. So from that side of things, being able to scale this exponentially on a day is not a problem. And there are governments that have a serious need to understand the population's health so they can determine the hotspots and where they should be positioning care better. The UAE is a perfect example, and for many reasons. One, the government here pays for 80% of healthcare. So when they're paying for that much and trying to attract people to the region, there are 9 million people living in the UAE at the moment, escalating quickly. They want to take that by 2050 to 35 million. So that can only be by expats coming in as starting to live here. The healthcare system is very mature. It's very good. And they want to understand if we're paying for the healthcare, who should we be looking after? So they've got a real desire to understand where the health of their population sits. The only way to do that until AHI came along was try to get everybody into the doctor to have a health check. And again, if you could get them in once a year, great, but it really doesn't give you that accurate snapshot of your population because you've got the highest rates of obesity in the world in this region, which means the highest rates of type 2 diabetes, heart disease, and so on. If you can identify this early, then you can bring people into the care pathways and cost yourself a lot less on medication and maintenance than hospital stays through people, basically driving off the cliff because by the time they get to the doctor, it's too late. They need
Yeah.
hospitalisation, they need urgent care, and they're escalated into a far bigger system where it could be a heart issue and so on. So that's where we fit in. And we're actually going to do a national screening here shortly with one of the government officials. And we're looking to screen everybody over the age of 20 for heart conditions initially, where we can identify through actually a medically approved capability that's being put into our application to see where the heart disease side of things starts. And the reason we're doing this is a particular gentleman, which I won't mention his name just yet because we're still putting everything in for the press. He had a heart attack in 2018. If he was using our technology, he would have known far earlier that this was going to take place and he could have done something about it. So he's extremely driven to bring this to the population. My view when we were initially going to do it was everybody over 40 should be screened. But then we looked at the data and it actually needs to be everybody over 20 should be screened. So it's going to be quite an interesting outcome to see where is this going to land when we've screened that many people. And the beauty of the technology, we can do everybody on one day and do it as a national health incentive to bring all this data together and understand where that is. So our sweet spot is metabolic disease. And generally that comes from poor fitness, too much weight, and your general condition is bringing you down. It's all the comorbidities of those measurable parts of your body that are what we look for so we can identify them.
That's exciting. I hope that we can chat soon on that or when that does happen and how that goes. I'm
Absolutely.
excited for that. That's really, really very cool. So once risk is identified, what needs to happen for it to actually become prevention, right? Because that's the big thing, like why you and I are talking, because I'm so interested about what can we do prevention wise rather
If I
than
use an
remission.
American football terminology, this is where the quarterback comes in, right? This is get the ball to the quarterback so you can run it to the line. So what we do is we identify, and we identify via a partner. So the partner could be a government health agency, it could be an insurer, it could be a medical practitioner. They are the ones supplying the technology to the individual that's using it, not AHI. AHI is one step removed. So when that medical practitioner, health provider gets this information, he's the one running to the line. He's the one saying, right, this is what I'm going to do with the ball now that I've got it. And he
Yeah.
directionalizes the care. He decides where am I going to place this human because I understand what's wrong with them. I understand where they're heading and how am I going to circumvent that and start them on a process to recovery. The beauty of the information is it's validated, it's real. And it gives something to that individual that's tangible that they can look at. Now, you see, I wear 2 rings, right? These are both wearables that I'm testing. I won't say the names because this is not here to promote anyone else's platforms. But what I like about these is I test them against our technology. So I want to see what is this telling me versus my technology because I know how we've validated our technology against real medical devices, gold standards, and so on. And whilst they're somewhat out, they have a place. The problem with a wearable is you can't get it to as many people. So the beauty of what we do, and if you look at most medical practices, they have thousands of people on their books, but those people come in episodically. They come in because there's something wrong at the time. This gives a doctor an ability or a medical practitioner, a health provider, an ability to say, I'm going to look after everyone in my database because I have now got a technology I can rely on to give me information that I can react on and to bring people in earlier than they would have come in if I'm seeing escalation in the markers. Again, the markers that we're providing them are the same things they would want to take if I was physically in their practice. We've digitized them to hand them back to that practitioner. So I think it provides better duty of care, better oversight over individuals. It allows you to reach your entire you database or client base within a medical practice at a very, very cheap inflection point. Now that I won't say what the price points are simply because it varies so much in different parts of the world, but we can deliver this technology for cents in the dollar. So when you do that with the ubiquity of the phone, the fact that it is the computational analysis happens on the phone, there's no reason everybody shouldn't have access to a tool like this to then provide it to their health provider.
So you described a model where you're not trying to replace care providers. You're trying to route the right people into care. And then how do you think about your role relative to doctors, pharmacies, maybe insurers, wellness platforms?
I really see us as a adjunct because there are people that need to be into care that are not getting there till it's too late. And there are a lot of people in the waiting rooms that don't particularly need to be there if that information could have been provided before the individual sat in the waiting room, started taking up the time and the cost. So there are 2 things you've got to look at, especially in the US. The healthcare system is a money profit driven marketplace. So we want to be careful about how we come into that marketplace because we're not trying to take people out of their surgeries. What we're trying to do is put the right people in them. From the pharmaceutical side of things with the pharmaceutical companies and the pharmacies, we're identifying people probably much earlier than they would start on some of these medications to stop them falling off the cliff and having hospitalization, heart attacks and strokes and so on. So if you like, we're a piece of the workflow. We don't want to be, everybody comes into technology and talks about disruption. No, 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 no. That's the wrong approach. It's like telling Coca-Cola, use a different can. There's a set way of doing things. How do you streamline into it to give better health outcomes, generate further revenue for the utilization of that with the medical practitioners, give them a better duty of care for their insurance, and make sure people are getting the care that they need and want when they need it. And even if you look at insurers, and again, I'll bring it back to the US because that's the primary market we're talking to here. People are underinsured in the US because they go online now. The days of mum and dad sitting on the couch with an agent that talks about what the right health and life insurance would be, they're over because everyone's cutting costs. Now you go online and you buy your insurance online and you fill in a number of forms. And we've interacted with tens of dozens of insurers at ITC Vegas, at all the different insurance conferences. And each year they basically increase the insurance premiums based on the lies that they were told the year before they had to pay out for. So it's not the way to run insurance. And people go bankrupt because they can't afford their medical bills because they've underinsured themselves. So a technology like this not only helps people be healthier and streamline to better care, but it helps the insurer understand the human and underwrite them properly on their insurance to give them the care that they will need. So in the event that they have something go wrong, they're insured properly to cover that. And we've got insurers around the world already using this technology to underwrite. Not in the US yet, but other parts of the world where they've taken the initiative and said, we really want to understand the humans that we're looking after, and we're going to use this technology and we will utilize that to underwrite you. And when they utilize this technology, rather than just fill forms in, they get discounts on their insurance. So that's a huge motivator for people to look after themselves, probably get the right insurance. So we've been quite fortunate with some of the organizations that we've already got on board that are doing that.
Excellent, excellent. Okay. So AHI is embedded onto other environments as an SDK or like a link. What does a partner ideal for you, or what makes a partner ideal for you, and what makes an implementation succeed?
So listen, I said it earlier, and I'll just reinforce it. The perfect customer for us is a large pre-existing population, policyholder base, user base. And this could be everything from Freeletics as a fitness application that wants to go a level deeper into understanding the people that they've got coaching through their platform, to a Spartan race organization that have got 1.5 million people a year racing that need to be insured for anything that could happen to them while they're racing. It's understanding that human at the onset. We ideally a platform with 10,000 or more users, just to get the cost of scale right. Most of our platforms that we're engaged with now have over 100,000, multiple millions. Some of the big insurers we're talking to have 15 to 20 million policyholders. In China, we have one we're talking to, there's 183 million policyholders.
Wow. Okay.
So what we look at is scale, and the ideal customer is one that has a digital environment that's known, used, and trusted. Because you don't want to come in as AHI and start saying to 183 million people in China, hey, use us, we're great. Whereas if their insurer that's already insuring them comes and says, we've increased some of the capabilities within our technology, if you utilize the following parts of the technology, you will get better premiums, better prices, more coverage.
Beautiful.
It's a win-win, right? Everybody wins. So that's the kind of customer we're looking after. We're being approached by World Health Organization partnerships that are doing things in Africa, here in the Middle East, because you've got huge populations surrounding us. I live in Dubai, as you know from our previous conversation, and you've got 9 million people here. Saudi is just up the road, 35 million people. Egypt, over 100 million people. So the concentration of humans in this area, when you look at the MENA region, is hundreds of millions of people that require care, with sometimes governments that don't have the best healthcare systems or budgets. So to be able to bring something with the ubiquity of a mobile phone into those systems and offer that technology, I think is something that will happen with the future in time. As you get countries like the UAE who are very forward thinking, setting the standards, you will see the rest of the region just start to follow, because they tend to do things as first mover advantage here and take them to the rest of the market, which is a great advantage for us as well.
What do people misunderstand about digital biomarkers or population screening when they first hear about it?
I think it's the big brother thing, right? It's why would I give this information up? And when you say biometrics, people shudder because they're thinking you're identifying me, you're watching where I go, where I'm driving, who I'm with, all of
It's
my
too
movement.
much.
It's
You know
fine
too
to
much.
Yeah, I think because, and we won't mention names again, there were a number of very large not government, but international companies that you walk into their stores and they were using biometrics to understand what you were stopping or looking at when you entered the store. They were identifying you to feed you information. They got to wrap over the knuckles for it. That's not what we do. When I say we do a face scan, for instance, we won't take a video of your face. We just take the blood flow, pigmentation change, and that we measure from. So nothing leaves the phone that's identifiable. Even when you do the body scan, you've got to be in form-fitting clothing to get it accurate. And no images leave the phone. It's processed on the device, and then the data is only what is shared back to the computation, and we give the outcomes in a report. Even though we do take images when we do the body scanning, they are not on your phone. You can go into your camera area, you can go into your photo area, you will find nothing. We basically run it on the fly and everything's deleted once we've got the computational information from it. So we leave it at that. That's the way. And that's why we trust it, because we do not take personal information that is
Good.
identifiable in any way whatsoever.
So, as you look to the year ahead, what are you most excited about in the shift toward earlier detection and prevention? And what do you think still needs to change for this to become routine?
So this year, when you look at the history of AHI, we started in 2014. Whilst we've had some modest revenues, I think this year is a turning point for the company because we've finished, validated, and go to market is ready on the two primary products that I've mentioned earlier with the digital health assessment and the digital health check. We have customers signed to launch. And this year is a revenue generating show it works year for us. So we have populations in excess of 150 million across different partnerships, both US, UAE, Africa, and some in Europe that we'll be working with. So this year is really about, if you like, waving the flag, is letting people know we're here, we're real, we're out there. So you'll see a lot more of this because we want to get out there, and thank you for giving me the opportunity to talk about it. This year will be a lot of promotion of the company and to build that base of users via our partners and getting the commercialization launched. And it's a little bit like you build a building and you drive past with the kids and say, hey, Dad built that. It's one of those things. I'm very proud of it because um, whilst I had a fantastic idea many years ago, I'm surrounded by some incredible people that actually built it. I'm a capital markets guy. I'm not a
Yeah.
medical based guy. My history is not in deep tech. So I surrounded myself with some people that are far smarter than me, know what they're doing, and have built something that it will truly benefit populations globally when it's utilized.
Kudos to you and the team. So, I want to follow you. Where can people learn more about AHI and the kind of partnerships that you're best suited for?
So obviously our website, which is ahi.tech. Very simple. We don't have an AU or a .com. It's just ahi.tech, TECH. LinkedIn, the company's on LinkedIn. I'm on LinkedIn, and we welcome anybody reaching out. We obviously have all the right ways to connect with us on our webpage. So people are more than welcome to come to that, ask questions, reach out to me directly, and always happy to talk to anybody and spread the news.
Absolutely. All right. Well, thank you for this, Vlado. I really, really appreciate it.
Pleasure. Fantastic, Scott. Thank you.
Thanks for tuning in to this episode of The Wellness Growth Show. If today's conversation sparked something for you, hit subscribe so you don't miss the stories, strategies, and insights from the front lines of wellness innovation. If you're a founder, operator, or health leader exploring growth into institutional markets and have a story worth telling, I'd love to hear from you. Reach out directly on LinkedIn or YouTube. And if you found this valuable, share it with a peer or post it online. You never know who needs to hear it. Until next time, stay well, keep moving, and keep building what matters.